going to present it's on posterior polar cataract, the planning and execution of a case of posterior polar cataract. As you all know, posterior polar cataract is sometimes a challenge, and there are certain features. It's congenital in most of the cases. It can be sporadic. Family history is there, so you need to check the family. It's bilateral. In most of the cases, there is no sex predilection, and the incidence is 3 to 5 per 1,000. And why is PPC so important? The moment you get to see PPC, you think that there's a strong adhesion of the posterior capsule with the weak posterior capsule with the cortex, and there's 26% likelihood for a defective posterior capsule, high rate of intraoperative defect. And one thing you must remember is the risk is more if the patient is a young myope. The risk of PCR is more. And there are basically two types. In 65% of the cases, you'll get to see stationary type, which are quite well defined like this, or there might be onion ring pattern around the central opacity, which is quite well defined, or there are mild small satellite lesions around it. These are stationary in type, and they are less dangerous as compared to the progressive type. If you get to see riders like this extending to the periphery, if you get to see scalloped areas of opacity around the ring, and if you are very, very particular, you can even get to see posterior capsular pre-existing dehiscence. So the 7 surgical steps that I follow, and the first and the most important step is a good dilated examination of the posterior capsule, and try to see beyond the posterior capsule whether there is anything extending behind it or not. If you have an anti-segment OCT, you can even go for it. It clearly shows the posterior capsule, as you can see in the first one. And if there is a posterior capsular thickening and adhesion, it will show in number C. And if there is a dehiscence, it will show in number as in number D. And even UBM is also very good. If the posterior capsule is intact, it will show like this. And if you get to see a fistal sign like this, you should be cautious that you might end up with a casualty. Anyways, preoperative counseling is very important. I always make it a point to draw things like that and risk of nucleus drop like this, so that I am saved if in the post-operative period, the patient cannot complain to me. The risk of posterior capsular rupture has to be explained. Possibility of nuclear drop has to be explained. You need a relatively long surgical time. Secondary posterior capsular intervention might be required. There might be delayed visual recovery. Pre-existing amblyopia might be there. So all these things are to be discussed with the patient. Now coming to the surgery itself, we always target at a smaller rhexis. Rhexis should be around 5 millimeters, because we need a good posterior anterior capsular platform on which we can put in the lens later on and do an optic capture if we end up with a PC tear. So it's useful. Doing a rhexis is not at all difficult, because you normally have a very good red reflex. As you can see, I always do a dry cortico-capsular separation. This is from the side port first on one side, then you use the other side port for the other side, and you do it all 360 degree. That will help you in the separation in the later periods, because these patients used to generally have thick cortical matters and a very thick epinucleus to work with. Now, central trench is very important. You make a 50% trench. You shouldn't go beyond that, but the trench should be long enough. It should be covering the whole of the area where you have done the rhexis. And after you have done the central trench, you should go for a hydrodelineation and not hydrodissection. As you all know, that hydrodissection is extremely dangerous. You need to be very sure where your irrigation tip is, and inject very small amount to be sure that you are in the right plane. Do not try to force in fluid, and everything you do in a PPC should be very slow. And a very good technique, I've reduced the speed of this video to properly explain. This is the Vasavada's inside-out delineation, which I had been doing recently. After having done the trenching, I try to find out the plane by very small volume of injection in the epinuclear plane, and then once I get the plane, I inject furthermore, and when I see that the central nucleus is popping up, I stop it. Slow motion phaco under low infusion pressure. I want to emphasize that the low infusion pressure is something which is very important. You should do everything very slow, low infusion, low irrigation, low vacuum, low flow rate, everything low, go slow. Most of the time your lens is not very thick enough, not very hard, so that you can easily take them out. Like, wait, this is a mistake. This is something I've learned from my mistake after having done this old video. As you can see, I did a central trench, and then as you can see, I started and tried to remove the central chunk first. This is something you should never do in a posterior polar cataract. Once you try and take out or pull the central chunk, in spite of doing everything right, staying at the close to the iris margin, iris level plane, and doing everything right, you might end up with a PC tear like this. So whatever you do, you try and remove the lateral fragments first, inject viscoelastic. Many a case, if the fragment is stuck near the incision, you might have difficulty taking it out with the phaco tip or the irrigation tip. You inject viscoelastic between the capsule and the material. You place push some viscoelastic, the nuclear material will come at the center. VISCO-VAULT is another very important technique and very good technique which I had been using recently. As you can see, after doing the central debulking, here I'm debulking more. I make a small nick on the side of the nuclear fragment. I try to find out a hole through which I can inject viscoelastic. I inject small amount of dispersive viscoelastic and then a larger amount of HPMC, make a space between the posterior capsule and the nuclear fragment, and then complete my phaco. Even for cortical removal, you should start from the periphery and then come to the center. And it's a rule that you should always do everything outside in, not inside out. And injecting viscoelastic before removal of all the instrument is another very important step, and it is particularly important in myopia as well as in cases of posterior polar cataract. This is another very important case I wanted to show, that as everything was going all right, and towards the end of when I'm trying to remove the last fragment, I could see that there's a posterior capsular tear. In this particular case, in these sort of cases, I do not take out my instrument. I just simply reduce my bottle height to 55, 50, or even to some extent, in certain cases, 60, depending on the amount of material which is left behind. I slowly take out rest of the material and then inject viscoelastic and take out the other side. Because if you try to take out your instrument at that particular time, even if you inject viscoelastic, you cause some amount of turbulence, some amount of shallowing of the anterior chamber, and hence there's always chance of increasing of the tear. If there's no vitreous disturbed, you can do it that way. In certain cases, you might end up with a posterior capsular plaque like this. As you can see, if you have the plaque like this, you inject the lens, let it be in the sulcus, and then you do a posterior capsular rhexis, and along with the rhexis, you remove all the plaques that are there on the posterior capsule, make a small sized hole, and then you finally place the lens under viscoelastic, put further viscoelastic above. At this point, you can also irrigate very slowly to remove the left out cortical remnants, or you can slowly or gently suck them out, and then finally you do an optic capture of the lens. So PPC is a challenge, but it's not a nightmare. Careful preoperative evaluation, proper counseling, inside out hydrodelineation, slow motion phaco, removal of the central fragment. Last will ultimately end up in a happy outcome. But if you do not plan properly, if you've got a poor technique, it will further aggravate the mess and you'll have complications. Thank you. Thank you very much. I think we have.
Yeah, that was an excellent demonstration, Arupda. I think we are running short of time now. But still then I would, yeah, now we are running short of time. But still then I would like to just ask you one question before we finally end. Is for a PPC, would you like, this is mainly for the beginners, would you like them to always have a 3-piece lens as a backup before you start surgery?
Yes, that's very important. You never know when you end up with a large PC tier, and you should have a 3-piece lens as a backup.
And a vitreoretinal surgeon handy, and maybe if we are not as dynamic as you are,
No,
comfortable with anterior
I
posterior
tell you one
surgery.
thing, if you have explained everything to the patient, it's not always necessary to remove the lens, even if you have a nucleus drop the very same day. You explain it to the patient that we'll wait for a while, put you on steroids, reduce the amount of inflammation, and then take care of the problem. I think you don't need to hurry up. Only thing is counseling the patient, taking good care of the patient, talk to the patient beforehand is more important, and keep things in drawing. This particular one of my patient who had a retinal complication later on has gone to the court and had to face the legal consequences. And the judge, the moment he saw that it's all drawn, he came to know that I've explained it to the patient before and that this sort of complication might happen. And he didn't take any step as released and didn't penalize me. So I
Excellent.
think
That's word from an expert. Thank you very much for making us a part